Hello, everybody. Welcome to another edition of GYN ONC Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky, and my colleague here is
Frank Lawton from London, UK.
very good. In today's GYN ONC Garage, what we're going to do is talk again about aspirin. And in this case, we have a carryover from a previous paper. And that previous paper found that there was a 13% risk reduction when aspirin was being used with high frequency. Today's paper, which is a little bit different, adds something, and that is that it adds the consideration of genetic susceptibility by considering a polygenic score, which incorporates more than just the BRCA genes, incorporates the additional risk genes, all of which probably have a lesser risk than BRCA. And when it does that, it proceeds to find that the same 13% risk reduction applies when you consider the polygenic score. What this boils down to is that a major statement is being made by the paper that at this point, maybe aspirin is very beneficial, even though there's a genetic risk from a variety of genes or mutations in those genes. The thing that I have to point out, though, to the reader is if you take the aggregate of all the known genetic predispositions for ovarian cancer, it counts for less than half of the genetic family related ovarian cancers. So there's a lot we don't know about what specific mutations cause ovarian cancer, and you can only consider about 40% of the effect due to the genetic mutations that we do know. The other thing is that the paper displays the results so that we're really not comparing a wild type population with a increasing risk score by their polygenic score. We're comparing those with scores less than the median and those above the median. There's no control group that would be the wild type, which would be without any known genetic mutations. So all that being said, it may well be that in the comparison mixture, that the control and the comparator group are really about the same, and that the result is really not yet proved to be meaningful in a prospective population. Frank, what do you think?
Yes, I picked up on that as well. I thought that it's difficult to get a control group, obviously, but I was disappointed that the two groups essentially could actually just be the same group. The polygenic group is clearly it's the BRCA gene that is dominant at the moment, as far as we know from that point of view. It was disappointing, I think, to say that for them to compare the polygenic with the BRCA. We actually should have a wild group, just a group of women who don't have a family history and don't have a genetic susceptibility. As I was saying before, perhaps this is time to put aspirin to bed. I think we've got about as far as we can without a big randomized study, and I'm not so sure that the results of any aspirin-associated ovarian cancer treatment are significant enough for anyone to launch a large study of aspirin use, whether it's in the genetic susceptibility ovarian cancers or any others. It's an interesting paper, and clearly, aspirin has a role in somewhere, but I don't think we're going to get very much further than we've got so far.
Sure, and I'll pick up what you just said. Significant enough. Now, the 13% risk reduction, that's sort of what we've been talking about in both the first papers and in this paper. But now you're going to consider another paper in terms of the effect upon ovarian cancer survival of aspirin. And please emphasize, is the effect significant enough? So why don't you take up that paper?
Okay, this is what's called the OPAL study, which is an Australian study running from about 2012 to 2015, recruiting women with ovarian cancer and looking at lifestyle. The idea being lifestyle changes, could they possibly influence either benefit in general or survival? And lifestyles such as diabetes, weight, genetic problems, concurrent morbidities, etc., things like that. So they looked at about 900 patients in this study, and this was self-reported, looking at women who admitted to taking aspirin less than once at 1 day a week, more than 1 to 3 days, 1 to 3 days a week, or more than 4 days a week. Although the dose isn't actually said whether it's low dose maintenance therapy for thrombolytic problems or not, but that was how they chose it. The problem with a big study like this is disentangling the effect of aspirin plus the effect of all of the other bits and pieces, and they've tried to work hard on it to try to count for history and diabetes and racial characteristics. They've done their best, but I think the problem is things get you need disentanglement in this sort of study, and I'm not sure they've disentangled it as well as they could do. So they've got 900 odd patients. They've chosen a good group to start with. They've chosen a group who are in complete remission, based on a CA-125, and presumably have had maximum cytoreductive surgery. They've had to survive for more than 12 months in order to be employed in the study. And so clearly they've chosen a good prognosis group, and the endpoints are survival, progression-free survival and survival. The results, it's very interesting. The results are similar for whether or not they're users or non-users, but significantly higher for patients who were started on aspirin after diagnosis or after surgery, which is, and the other results are that any beneficial aspirin seems to be associated with a frequent user, so more than 4 times a week. And what they've shown or what they claim is that there's a 35% increased survival for any use of aspirin, but they say that this relationship is weaker for PFS than overall survival. Now that's unusual, because normally a lot of studies will show an improvement in PFS, but not an improvement in survival. I mean, PFS is used erroneously in some studies to show that this is beneficial, and yet when it comes to overall survival, there's no difference at all. But they say the survival difference is 2.5 months at 5 years. Now, 2.5 months doesn't sound very much, and obviously these are patients that have been given other chemotherapy. But their claim that things, well, yes, but even some of the more exotic treatments like bevacizumab basically only gives something like a 5-month improvement. I'm not so sure that this is not a randomized study, so I'm not so sure that they can say, well, this one shows 2.5, this shows 5, so therefore it must be almost as good. I think the arguments I have is, well, one of them is 126 patients were started on aspirin post-treatment. So they weren't taking aspirin before the diagnosis, they were started afterwards. Why was that? Was the physician, the clinician involved, already aware of the data and felt that giving aspirin was advantageous? Did the patient ask for aspirin because they'd read a study somewhere else? So I'm not so sure that group of patients who were given the aspirin afterwards are representative at all. The other thing is that there's patients with FIGO1 and FIGO2 disease, and I don't know whether or not they were included in the final analysis. Obviously, FIGO1 patients wouldn't even get any, well, presumably wouldn't get any chemotherapy. And the other thing is, of course, that let's just say that PFS is associated with primary surgery and primary chemotherapy, and therefore that's why there's little effect on PFS with aspirin. Once you relapse, presumably you're given adjuvant or you can further chemotherapy. And is it the further chemotherapy that's improved the survival, or is it the addition of the aspirin that's produced the overall survival? And that's the complication, I think. We don't know. Presumably these patients were treated at relapse with aspirin plus something else. And obviously, without actually doing a randomized study, I don't think we're going to get anywhere here. And nobody is going to fund a study of aspirin plus or minus some other chemotherapy in patients with ovarian cancer. So it's interesting. I think the anti-inflammatory effect of aspirin is useful. This paper also looked at paracetamol, Tylenol, and it didn't make any difference. So it seems to be not just the analgesic part, it is the anti-inflammatory effect of aspirin. But I don't think it's actually really improved our knowledge of how to manage ovarian cancer.
Sure. I agree with you. I'll make only 2 points, and one is actually making the first point again. But one thing is that I don't think that they really considered the effect of neoadjuvant chemotherapy in this, and those would be people who would benefit from sort of a shift to a more minor surgery or a less extensive surgery due to the neoadjuvant, and might then be on one side of aspirin or the other, not having aspirin or not needing aspirin or else. But that's a group that I don't see them clearly mentioned in the paper. The other thing, though, is returning to the 2.5 months. Is there a group that could benefit? And it seems to me that maybe from the patient population, for the person who just has to last long enough to see their child married or to make some sort of event, that figure would make a lot of sense. Would have a lot of appeal. On the other hand, it's a profile of distribution, and whether you actually are going to be at that median or not, it is just hard to say. So for that person, maybe the consideration is that ahead of time about the engagement, ahead of time the endpoint, and you're going to try everything you can to last it out, even though you have late stage disease.
Yes. But of course, is it that these patients are continuing with their 3rd or 4th line chemotherapy to get that extra 2.5 months, as well as the aspirin? So they suffer all the side effects of 3rd or 4th line chemotherapy and have aspirin as well, and that is not apparent in the paper as to whether that was the case. Clearly, these patients are not just given aspirin in their last few months. At least I assume they're not just given aspirin in their last few months, with their physician saying, well, if you take aspirin, the chances are you'll live for a couple of months longer. I agree entirely about the goals. They're very, very important, but I'm not so sure that a physician could actually go to a patient and say, and if you take aspirin, you'll live longer. I don't think these data show that.
No, I agree. And I may have to lean more towards there's a possible risk reduction than there is a possible survival advantage.
Yes.
So.
Yeah, and of course, there's nothing about the side effects of low dose aspirin in the paper at all, and we all know what the side effects are, but there isn't anything about did patients discontinue aspirin treatment. There's nothing in the paper about that. The assumption is that they all just kept going until something happened.
Absolutely. Well, let me just say that we want people to be able to see what the paper is that we've been talking about. So I'm going to leave that up for a few moments. And I thank you again, Frank, for doing such a good job and a thorough job for us. And I'm looking forward to doing this again next month.
Absolutely. Looking forward to it.
Okay, very good, Frank.
Okay, then.